Good morning. This is Medication. Medication is your first psychiatric consultation and the introduction to physiologic reserves on page 8. The physician, patient, and attorney need to understand the concept of physiologic reserve. The physiologic reserve is the ability to tolerate stress from heat, cold, chemicals, medications, and other stress, both long-term and short-term. When the stress exceeds the physiologic reserve, there is death or other adverse effects. The simplest example of acute stress overcoming physiologic reserve is the LD50. The LD50 is the dose of any substance that results in 50% of the subjects dying after exposure. 50% of people who drink 6 liters of water, caffeine equivalent to 118 cups of coffee, or 13 shots of 80-proof liquor, die. Acute stress can cause cardiomyopathy and death by raising adrenaline and causing cardiogenic shock. It is treated with beta blockers and supportive care. It occurs in older women and is sometimes called broken heart syndrome, as it can cause death shortly after the death of a spouse. It occurs in 5% of female heart attacks. Chronic stress is more complex. Exposure to medications is harder to assess for effects less than death. Thalidomide caused vulcomyia, children born without arms and legs. It was not discovered for years because it was rare. Over 10,000 children were born with a range of severe and debilitating malformations. However, it occurred at the rate of about 0.3 per 100,000 births to 4.6 per 100,000 births. In psychiatry, tardive dyskinesia is a common example of a long-term stress on the physiologic reserves. In the past, about 50% of patients in state hospitals would have tardive dyskinesia after several hours of treatment with antipsychotics. It became a practice to have drug-free holidays to identify the presence of tardive dyskinesia and the need to continue treatment with antipsychotic medications. Drug-free holidays are now not common practice because of the notion that it is more important to delay relapse than to prevent tardive dyskinesia. However, that should be the patient's choice. Antipsychotic medications are effective because they bind with the D2 dopamine receptors. Tardive dyskinesia is caused by the loss of the cells with the D2 receptors. Chlorpromazine was introduced into psychiatry in 1954. In 1956, 100 milligrams of chlorpromazine was used effectively for the treatment of acute intermittent porphyria. Acute intermittent porphyria is a known medical condition. Unlike schizophrenia, the remission of the psychosis with chlorpromazine is not a cure of the acute intermittent porphyria. In 2000, Kapur and others determined that 2 milligrams of Haldol achieved a 50% saturation of D2 receptors. They also determined that 65% of D2 saturation achieves a therapeutic effect. 72% of D2 saturation raises prolactin levels, and 78% of D2 saturation causes extrapyramidal side effects. Finally, D2 saturation above 65% did not give additional therapeutic response. One can conclude that keeping the D2 saturation at 65% and below 72% will give its maximum therapeutic effect with no elevation of prolactin and minimal risk of extrapyramidal side effects, including tardive dyskinesia. Kapur et al. Recommended a starting dose of 2 or 3 milligrams a day of Haldol. Myself, I recommend 75 milligrams a day of Thorazine, as it is effective for acute intermittent porphyria, bipolar disorder, anxiety, aggression, and insomnia, in addition to schizophrenia and other psychosis. Chlorpromazine does not prolong the QTc interval like Haldol. It is much smaller in this effect. If a low dose does not work, the primary physician should hand the patient off to the psychiatrist. This is page 12. Tomorrow I will review the rise and fall of the physiologic reserves from conception to death. Thank you for your time and your kindness. Have a great day.